Well, can we avoid them? Well, the right answer is not to apply radioiodine. That's the most convenient and easiest way to avoid side effects. But my presentation is on this topic. I think this is the outline, some principles in radiobiology, the effects on cellular level of radiation, and I will conclude with the side effects we may observe in clinical practice, just to give a brief overview of what we can expect when we treat patients with radioiodine. Now, it is highly important that when we talk about side effects, you have to realize that you have to have some knowledge on radiation-induced cellular or tissue effects. And if you treat a patient, for example, with radioiodine, usually it's taken up by the specific cell. And we see it with radioiodine, but we see it also with lutetium dotatate. It is internalized into the cell. And there, it has already different effects. You can see here damage to the cell membrane. You can see here, due to the radiation, its effect on DNA, but also on the mitochondria. But you have to realize that also features from cells, the typical features, may be destroyed by radiation. A typical cellular effects. Another issue, of course, is when you treat a patient with radioactivity, you're not only dealing with the self-irradiation of the cell, but also by the cross-fire irradiation. And that means that the radiation also may cause damage to neighboring cells. And it can be either malignant, but it can also be a benign cell. When there is damage to the cell, it depends on the repair mechanisms of the cell, what will happen thereafter. Either you may observe a complete repair that may end up in a cell survival. It has no consequences. When there is misrepair, especially on DNA level, it may induce tumor formation, the carcinogenesis, and that is a typical stochastic effect, the genetic effect, the genetic alterations that end up in cancer. And at the other spectrum, when there is no repair mechanism, it may cause, or it will definitely cause, cell death. And it depends on the effect of the irradiation, what will happen. The cell death, it's the non-stochastic effect or the deterministic effect. And in fact, that is the antitumoral effect. That is what you want to achieve. But it is usually at the cost also of stochastic effects. On the other hand, you have to realize that cell death is also one of the features of toxicity. So there are three mechanisms: repair, misrepair, and no repair, which may end up in nothing, the stochastic effects, and the antitumoral, but also the toxic effects. Another important issue is that irradiation may cause damage, not only directly, but also indirectly. And what is the indirect pathway? Well, quite simple. It's the formation of free radicals. It may induce also free radicals. So not only the direct irradiation, but also indirect effects may cause damage on a cellular level. You see here the pathway, how it works, and it's called the production of reactive oxygen species, the ROS, that may end up in, well, the formation of different compounds, toxic compounds, and that may cause cellular effects. And it depends here again on the repair systems shown in the previous slide, what happens. Now, what are the repair systems, or what defense mechanisms do we have to overcome the cellular antioxidant effects? Well, cells have an enzymatic antioxidant defense mechanism to counteract the ROS. You see them here, three mentioned on this slide: catalase, peroxidases, and the superperoxide dismutase. And the reason, or the final effect, is that all the free radicals will be destroyed, or in fact metabolized to non-toxic agents. However, in addition to the enzymatic antioxidant defenses, there are also non-enzymatic antioxidant defense mechanisms. And you see here some compounds that may interfere or, in fact, may avoid the toxic effects of the radicals, the free radicals. And the typical examples, of course, are vitamin C and E, but also copper, etc., etc. So don't forget this mechanism. It's also highly important when we talk about irradiation, when we talk about radionuclide therapy. One comment on the effects on the cell membrane. If the target of radiation are lipids, you see a complete cascade that may occur on the cell membrane, and then, of course, it may have effects on membrane alteration, activation of signaling pathways involved in cell death or cell survival. Don't forget this mechanism. It's not only DNA, which may cause its effect, its antitumoral effect, but also this mechanism cannot be neglected. In addition to the radiation effects, the direct effect, the formation of free radicals, there is another important issue. It's called the bystander effect. And the bystander effect is in fact occurring in cells that have not been crossed by particles, but that are damaged by compounds, by agents released from the cells that are hit by irradiated cells. So the release of enzymes or other toxic agents may cause, in fact, also side effects to neighboring cells. And this can be a malignant cell, but it can also be a normal cell. Don't forget this effect in nuclear medicine. One of the most important things to keep in mind is that we always think that the more activity we give, the more side effects may be observed. Well, it depends on the effect that can be observed. It can be deterministic or stochastic. And in some cases, there is a close relation by the amount of activity given, and in some cases, it's not. You have to realize, and if we talk about thyroid cancer or the treatment of hyperthyroidism, in fact, you have to realize that less uptake in target tissue may have effect on irradiation of non-target tissue. And it has also influence on side effects. And what does it mean? When we have a look, for example, of patients treated for hyperthyroidism, there is a huge uptake in the thyroid gland. Usually, when we talk about morbus Graves, it's in the range of 50 to 70%. And that means that about 30% is excreted. What does it have for consequences for the irradiation on your bladder? When you compare it, for example, with the huge amount of activity we give for thyroid cancer, and you see uptake of 1 or 2%, it means that more than 95% has to be excreted and will cause damage to the bladder. And that is the paradigm of radiation and its side effects. And you can see here, most of the iodine-131 activity is not taken up by the remnant, it is excreted, but what does it mean? What does it have for consequences? And how is it compared to the normal or hyper-functioning thyroid gland? You see here the typical uptake curves. We all know how radioiodine behaves in a hypothyroid patient or a hyperthyroid patient or in normal thyroid gland or when there is rapid turnover. Of course it has consequences on the target tissue, but such patterns also have consequences on normal thyroid or normal cells. When we talk about the side effects of irradiation, it's good to realize that there are two forms of effect. One is the deterministic effect. There is a threshold and there is a stochastic effect. And this, in fact, shows a relation between the severity of damage in relation to the dose, and this effect shows a correlation between the chance of an effect correlated to the dose. That is really the big difference between the two effects that can be observed in relation to the treatment. And as you can see, especially when we look at the stochastic effects, and that's why we also always have to be very careful when we talk about the treatment of children, but also the treatment of women, you see that the line is much sharper in children, and it means that the chance of inducing stochastic effects in children is higher than in adults, but also in women. And that underlines the fact that I'm always impressed by the fact that women are sensitive, not only to irradiation, but to all aspects of life. And that is shown in this slide. Well, here again, the deterministic effects, it has a threshold. The severity of the effect is dose-related. The more we give, the more the damage will be. In contrast, the stochastic effects, the probability of an effect increases with dose. There is no dose threshold, and the severity of the effect is not dose-related. Keep that in mind. But both can be observed in the treatment of thyroid disorders, either benign or malignant. Now, what are the thresholds for the deterministic effects? Because we know that they may appear, but what are the thresholds? Well, you can see here in this table some examples extracted from the literature. You see here the testis, permanent infertility, one single absorption dose between 3.5 and 6 gray, or a prolonged absorption dose of 2 gray per year. Ovary, in the same range. The lens of the eye, cataract, so between 0.5 and 5.0. You have to realize that when you are crossing the safety borders, you will definitely end up with such deterministic effects or non-stochastic effects. And also for bone marrow. What you see here, and that is just the example how the distribution of radioactivity changes in correlation to the uptake pattern in a body. You see here, when a patient has no thyroid gland anymore, you see that the irradiation to the bladder wall is much higher compared to patients who have a 55% uptake in the thyroid gland. So you have to realize that you cannot use this table for a patient with a thyroid gland or vice versa. Be very careful if you want to have a look or a closer look at the data or to estimate what the risks are for the patient. Use the proper tables, and they are ranging in literature, to my knowledge, from 0 to 80%. They are definitely available, and this is what you can see here. Thyroid uptake patterns ranging from 0% to 55%. What has its effect on the red marrow? Well, you see here the consequences. It's funny, the higher the uptake in the gland, the higher the radiation dose to the red marrow. And I always thought it would be vice versa, because there is less uptake in the gland and more circulating radioiodine. That's not true. It's only true for the bladder, but not for the red bone marrow. And you see here the effect in children. When there is no gland or no uptake, it's higher, the effect on the red marrow, compared to the adults, irrespective of the uptake effect. Now that's just the basic principle of effects and side effects, the stochastic and non-stochastic or deterministic effects, the bystander, the direct and the indirect radiation effects. But what does it mean in clinical practice? Well, the most important example of the stochastic effect, of course, is that we treat cancer, thyroid cancer, and we may induce cancer. And one of the most common or well-described side effects in the treatment of thyroid cancer is the induction of leukemia. But what do we really know from the data in literature about the induction of cancer? Many papers have appeared over the past years dealing with this topic. And I think this was one of the first studies, the risk of second primary cancer following differentiated thyroid cancer. And when you have a very close look at this table, there was a difference between women and men. I told you why that's important to make the difference and not put it in one whole group. There are differences in sensitivity between men and women in relation to radiation or side effects. And what is observed is that when the 95% confidence interval crosses the value of 1, or has 1 in between this, it means that there is no significant correlation between radiation and the induction of second primaries. And from this table you can see that there is not an increased risk in this population, because 1 is between this point 89 and 27. There is not an increased risk on head and neck cancer, lung cancer, breast cancer, digestive tract, bone, and melanoma. However, when you look at the genitourinary tract, there is an increased incidence observed in this population. On the other hand, when you look at men, there is no significant correlation between the tumor at this site, but there is an increased incidence on bone tumors observed in this population. But you have to realize and be very careful when you have a close look at the data. Only 1 case was observed in this population, in the study, compared to the standard incidence, and that makes a standardized incidence ratio of 100 based on 1 extra case. So be very careful to say, okay, there is really an increased risk on bone tumors due to the application of radioiodine. That's how you should read the data. When you look overall at the risk factors related to the occurrence or the induction of second cancers, you have to realize that other factors may also contribute to this effect, to the increased risk on second tumors. And then, from then, you may conclude probably that the role of radioiodine in this respect may be limited. What you see here, age is a highly important factor. The older patients are, the higher the risk on second primary tumors. And this is the group of patients that underwent radioiodine treatment. So radioiodine might be an important factor, but you see age is also an important factor. Lucky as we are, there is no difference between male and female in the induction of cancer, although women are more sensitive to irradiation. One of the most important issues is the history of previous primary cancer. So if a patient had already 1 tumor, developed thyroid cancer, the chance of having a 3rd cancer thereafter is higher in that population. And finally, here you see the relation between the cumulative iodine-131 activity and the risk of thyroid or second primary tumors induction. And from this data, it was concluded that many tumors, the risk on second tumors is increased, but there seems to be no relation with the amount of activity applied. Now, if we use radioactivity, we apply radionuclide therapy, you can see that over time there is an increased risk, especially in the first years. Then there is here a low prevalence of second primary tumors, but between 5 and in fact 10 to 12 years, the risk on radiation-induced second tumors is slightly increased, and then it normalizes again and is comparable to the prevalence of second tumors overall in the population. So during this time period, there is a slight increase, which is probably related to the application of radionuclide therapy, and thereafter it normalizes again. As I told you, many papers have appeared on this topic, and what we know from all these studies is that in fact leukemia is correlated to the use of radioiodine. We know that there is a slightly increased risk on leukemia, but not on other tumors when you put all the data together in a multivariate analysis. So we observe some increased risks, but the question is it all related to the treatment with radioiodine? Well, just a very nice example that sometimes it looks as if the incidence is related, the increased incidence is related to the treatment of thyroid cancer, but other factors may contribute to that. And as you can see here, this was a study from my group. We observed a slightly increased incidence of second primary tumors in the female genitourinary tract. That was significant. But that was the second primary tumors following thyroid cancer. So we expected to have a close correlation between the treatment and the induction of second primary tumors. When you combine, however, all primary tumors and second primary tumors together and then reanalyze the combination of thyroid cancer and other tumors, you see here, and that is really interesting, that there was a highly increased risk on breast cancer in the whole population. And from this data and from other data and literature, we know that radioiodine may induce second primary tumors, especially leukemia, but some patients are at risk at all to make second primary tumors, and especially female patients do have an increased risk on breast cancer. Don't forget it, and it has nothing to do with the amount of activity. It's a genetic problem. So women with thyroid cancer have an increased risk on breast cancer, but also the opposite way. Don't forget it. And that means that it is not always radiation induced. The non-stochastic effects are less complicated, probably. When we go, first of all, to the lacrimal gland, we know that xerophthalmia may occur in about 25% of the patients in the first year. Thereafter, it's going down a little bit. But even after 3 years, about 40% of the patients may have xerophthalmia. The question, however, is what is the severity of this in clinical practice? And is it a subjective aspect, or is it really an objective aspect? I will show you later how it develops over time. And you see here, for example, in this study, they compared a group that was exposed to radioiodine and not exposed to radioiodine treatment, and they were all suffering from differentiated thyroid cancer. And of course, patients had a foreign body sensation and eye itching and using artificial tear, etc., etc. But when you look at the unexposed group, there were also quite a lot of patients suffering from these symptoms. And in fact, when you see here, eye redness and burning sensation, that seemed to be correlated to the application of radioiodine. But when a patient is suffering from eye symptoms, it may have something to do with the air conditioning or other aspects, but it may not be correlated with the application of radioiodine. So be very careful to say your eye problems are related to the treatment I've given. The salivary gland, I think well-known problem in clinical practice, and it is quite often observed. You see here acute swelling, 12 to 60% of the patients may observe that. It's especially in repeated doses that this may occur: chronic sialodoadenitis, xerostomia, and taste changes. It is dose dependent, so it means that it is a deterministic effect. The higher the dose, the higher its effect. Of course, it can be prevented by a good hydration. You can start candies not before 24 hours after the application of radioiodine. If you give candies directly after radioiodine, it induces more problems instead of preventing problems. So you have to wait a day and then start giving the candies and sweets, etc., etc. Vitamin E and C, and of course, as shown in the previous presentations, recombinant TSH may lower the risk on side effects related to the salivary gland. When you have a look at the side effects on the lacrimal and salivary gland dysfunction, it was studied in this paper. It is a really nice paper in which patients were followed up. And what you see is that, and that's what I told you, sometimes it's difficult to get a good impression. Is it the patient that's complaining, or is it really an objective problem? You see here, 32% of the patients had subjective problems. However, there were some tests done. It was an objective percentage much higher than the patients complained about. So the problem is, what are we talking about? The same problem is when we talk about the eyes. You see, subjective, 25% of the patients, objective, 18%. So there are differences in how patients experience the problems and what really objectively can be established. What can be observed from this study is that over time, objective xerostomia and subjective xerophthalmia goes down over time. And you see here the percentages in the first year after the application, and it's going down to 13 or 40% after the third year. So most of these side effects are transient, but some patients, and it depends of course on the amount of activity applied, may observe or may have symptoms for years and years. One of the most important issues that we usually forget is the deterministic effect on the male fertility. You have to realize that spermatogonia have a high mitotic rate and are therefore classified in the group of the most radiation-sensitive cells. Don't forget it. Who is talking to the male patient about this side effect? And who is taking precautions about this? You do. You do. And what do you do then? What do you discuss with the patient?
They should not get somebody pregnant in at least half a year. 6 months, we say.
Yeah, that might be an option, but another thing is semen preservation. That might be a good topic for discussion with a male patient. So if you're going to start a patient with thyroid cancer, and you know that he is a high-risk patient, you have to discuss it, because he might come back over time, a couple of times. But nobody's doing that in clinical practice. But it may definitely have consequences. In women, and that's very funny, they're rather sensitive, but not the oocyte pool. It's present at birth, and it is relatively radio-resistant. Well, I mean, it's safe for our children, probably. When you look at the side effects, especially when we talk about the male effects, the gonadal effects in male thyroid cancer patients, there's quite a lot of data in literature available. And what we know, and that is what you can see here, that in a majority of the patients, we see effects on FSH. We see increased LH stimulation. And what can be observed is oligospermia in about 36% of the patients. So you cannot neglect this effect. You have to discuss it when we talk about thyroid cancer patients. Here you see the how radioiodine treatment affects the FSH production after radioiodine treatment. This is the basal value. After 6 months it increases, and then it normalizes again after a year or 1.5 years. So be very careful. You have to discuss it really with the patient. And also when you look at the other parameters, how it behaves over time, you see here a slight increase after 6 months, and then it goes down again. So take this into account, that it definitely may have consequences on male fertility. And if you're going to treat male patients for thyroid cancer and there is a high risk, talk about semen preservation. Well, what about, and of course, there is, the higher the dose, the higher the chance on infertility. It is rare when the cumulative activity is below 14 gigabecquerels, but thereafter, it's really a problem, or it might become a problem. Now, what about the effects on female fertility? When you look at the data in literature, well, a huge amount of publications have appeared on this topic. You see here from previous century, 2002, the last paper, quite a lot of studies have appeared on this, and especially related to two important issues. The first one is, does radioiodine have effect on the menstrual effects? Well, you see here the studies dealing with that. Yes, it definitely has effects on the menstrual cycles of a female patient. You see here ovarian failure, ovarian failure, ovarian failure, but it is all transient. So it may be observed in the first year after treatment, thereafter it normalizes again. But you have to realize that when you treat female patients, it is transient, but it cannot be neglected. Who is discussing this topic with the female patient? That it may have consequences on the cycles. And what about the reproductive outcomes? What is the consequence of the treatment or the application of radioiodine? Well, you can see here the studies dealing with that. In fact, what can be concluded from this is that there is no significant increase on miscarriages, no significant effects on infant outcomes, and that was in fact the message from all the studies. There were no significant differences between the treated patient compared to normal populations. So in fact, it has definitely consequences for the menstrual cycles, but not on the reproductive outcomes. The lung, we all know that when a patient has multiple metastases in the lung, you may induce radiation pneumonitis, and it may end up in fibrosis. Well, it can be observed in about 1 to 6.3% of the patients having multiple metastases. How do you avoid this side effect? Well, at least use an interval of more than 6 months. The tissue has to recover, and then you can go on. And another important issue is that you have to lower the dose. You cannot use the therapeutic doses up to 7,000 megabecquerels or 200 millicurie. When a patient has multiple metastases, you want to do your best and get the best result with 1 or 2 applications, Iodine-131 applications, but be very careful. You may end up with problems like that. And then the tumor is cured, but the patient is dead or has problems with his lungs. Be very careful with that. Now, a final comment on bone marrow. I think we all know that it may occur, transient leukopenia or thrombocytopenia. It is funny because the exact percentage or the exact incidence is not known. We all know that it may occur, sometimes it's observed, but who is doing here regular blood tests after single treatment to see what's happening with the blood? You do. You're the only one. You do? Nobody does it. It's really funny because it's probably one of the most observed side effects in clinical practice. But the problem is that it is usually transient. Of course, there are some risk factors. Elderly, when there are multiple bone metastases, when we use short intervals, and when the cumulative dose is high. So be very careful. It's usually reversible, but once you've noticed it, and especially when you're treating the patient more than once, you have to take this into account and implement it in clinical practice. Do a regular blood test. And finally, again, leukemia, second primary tumor, its effect, a stochastic effect. The incidence rate is still rather low, less than 1%. There are, of course, some risk factors, elderly, short intervals, and a dose higher than 20 or 30 gigabecquerel. It is rarely in lower doses, and the most common form observed is acute myeloid leukemia. You have to realize that the latency period can be more than 5 years, as shown in one of the first slides. There is an increased risk, so up to 10 years, and then it normalizes again, that risk on leukemia. But you cannot neglect this aspect. You have to take this into account. So the last slide before lunch. There are certain transient effects of radioiodine. They're rather common, not always measured, not always discussed with the patient. Some of them are deterministic effects, but there are also long-term side effects of radioiodine. They are rare, and one of the most common ones that should be taken into account is, of course, the induction of leukemia. Be careful for that, but there are other side effects that may be observed, as shown in this presentation. Thank you very much.